My name is Anand. I'm a surgical education fellow at Stanford University. Thank you for the opportunity to present on our study differences in coaching in single versus dual console robotic cases. And our research was supported by a SAGES Research Award. We don't have any other disclosures. So robotic surgery is, I'm sure you're all aware, becoming an essential part of the residency surgical experience, with trainees getting more exposure to robotic surgery through simulation curricula as well as through intraoperative experiences. However, there's very limited research examining how console case type can impact learning outcomes and experiences. So we sought to evaluate how intraoperative coaching and trainee autonomy during robotic surgery cases differ based on the use of a single versus dual console using a mixed methods approach. And we hypothesized that intraoperative coaching would be of higher quality and trainee autonomy would be increased on a dual console robot compared to a single console. So we had an IRB approved study. We looked at robotic single and dual console cases over a period from February to September of 2023 at our single institution. And faculty and trainees wore microphones throughout the entirety of the case in order to capture audio data. We administered pre- and post-surveys to our trainees and post-surveys to the faculty members. And these surveys included a variety of different demographic data information, but most importantly, they included metrics on faculty coaching, which was based on the Wisconsin Surgical Coaching Rubric, and on trainee autonomy based on the Global Evaluative Assessment of Robotic Skills, or GEARS assessment. For a qualitative approach, the audio from the cases was transcribed using online software and coded with NVivo. The transcriptions were coded with two of our researchers using a deductive approach based on the Wisconsin Surgical Coaching Framework, which you can see over there on the right side. So we had 18 cases that we included in our study. 7 were single console and 11 were dual console. And as I can see, there was quite a range and variety of case types that we were able to capture with our study, ranging all the way from hernia repair to liver resection. There were 11 unique attending trainee pairs that were included in our analysis. So for the first sort of quantitative data, what we can see is when we examine the relationship between robotic console type and resident autonomy and faculty coaching. So you can see that we separated it based on dual and single console using independent t-tests. And what we found was there was no significant differences in resident autonomy or in attending coaching scores based on whether the case was single or dual console. We queried both faculty and residents on our surveys about what they thought the percentage of the robotic portion of the case was that the trainee spent in the operating surgeon role. And when we looked at it based on PGY level with a chi-square analysis, both trainees and faculty, for both trainees and faculty, we found there was no significant difference in the percentage of the portion of the case that the trainee spent as the operating surgeon. And we also queried the same question and tried to identify differences based on console case type. And what we found was there was no significant difference in the percentage of the robotic portion of the case that the trainee spent in the operating surgeon role based on console type, regardless of whether you asked from the trainee perspective or the attending perspective. We also asked faculty about certain stress metrics based on the NASA TLX assessment score, and there were no significant differences in faculty stress metrics based on whether the case was single or dual console. And simple linear regression analysis found that there were a lot of factors that we looked at when we collected our surveys, including console type, and none of those had a significant effect in predicting resident autonomy or faculty coaching scores. And finally, when we looked at our qualitative analysis, so this was based on the Wisconsin Surgical Coaching Rubric and a deductive approach, what we found was for single console, the majority of comments were related to providing constructive feedback. For dual console, the majority of comments were related to sharing responsibility, but there was very limited comments during the case on guiding self-reflection or guiding goal setting and creating an actionable plan. What we can kind of think about here is that when you have a single console and the resident is sitting at the console, the surgeon has to be providing constant communication and verbal feedback with the resident or the trainee. Versus in a dual console, it's much more easy to share responsibility and switch control back and forth between the trainee and the attending. So we encountered a couple of challenges here. Initially, we wanted to randomize cases, but we found that there was actually a lot of pushback from residents and attendings where there was a pre-existing perception that having a dual console would be a better educational opportunity. Our institution also during our study period moved toward having almost all the ORs be dual console instead of single console. We had only senior residents operating at the console, and we had limited case numbers. So in conclusion, we found that there were no significance in resident autonomy or faculty coaching based on single versus dual consoles, suggesting that maybe in settings where single consoles are the only types of robot available, it can still be a great educational tool. And our qualitative analysis highlighted that coaching on self-reflection and goal setting and actionable plans is infrequently done and identifies an area of opportunity. Thank you.